Hi there. Welcome to another lecture for the Counseling 5480 Diagnosis and Treatment Planning course. In this lecture, we're going to talk about feeding and eating disorders. Well, there are actually quite a lot of myths about eating disorders out there that we're going to go through those and debunk those myths. Number one, eating disorders are a choice. This one is definitely a myth because eating disorders are actually complex biosocial cultural conditions that clients don't choose to have. Research showed that there's actually a multitude of factors play significant roles in who gets to develop an eating disorder. For example, in our media, there's this thin body ideal, right, which serves as an environmental trigger that has been linked to an increased risk of developing an eating disorder. Some other environmental factors include some kind of physical illness, childhood being teased and bullied by other people because of their body size, because of their weight, and a number of other life stressors. According to some record, the earliest eating disorder cases were actually associated with religious fasting. In addition to environmental factors, there's actually a genetic factor. So eating disorders usually runs in the family, like many other mental disorders, and biological predispositions that make individuals to be more vulnerable to developing an eating disorder. Next, everyone has an eating disorder nowadays. Well, this one is definitely wrong because yes, there's this obsession of food and weight in our culture, which kind of lead that disordered patterns of eating to be very common. However, clinically speaking, eating disorders are still comparatively rare. According to a recent report, there's only 9% of the US population reported having eating disorder in their lifetime. Now, this number is not significantly low compared to like other disorders, but still, it's definitely not true that the majority of our population has eating disorder. So in our daily life, we need to really watch out of our language and to not label people with the eating disorder or any other mental disorder. Next one, eating disorder behaviors only focus on food. This one is a myth because research showed that there are actually links between eating disorders and perfectionism, obsessionality, which can lead to a fixation on personal performance in academia or sports and so on and so forth. And many individuals actually report that they started doing eating disorder because they find that they can help them decrease their depression and anxiety level in the beginning. However, as the disorder progresses, their levels of depression and anxiety actually got increased. Since eating disorders are linked to biology, they're not treatable. But this one is not true at all because eating disorders are actually highly treatable. Yes, there's biological predisposition, uh, right, towards eating disordered eating behaviors, but they don't usually appear until when there's some stress in their life. So people can get better, but they need specialized, integrative, and personalized treatment. The earlier the intervention, the better the treatment outcome. Since my loved one is blank, and this could be any gender, race, or age, or any other variables, they will not develop eating disorders. Eating disorders, unfortunately, do not discriminate. They affect all races, all genders, sexualities, socioeconomic status, and religions, many other diverse variables you can add. whatever here, people can develop eating disorders also at any age. Eating disorders have a look. So somehow we may assume that, if he looks very healthy, he definitely doesn't have eating disorder, or she looks so skinny, she probably have some sort of eating disorder. No, we cannot tell from based on how they look, um, in regarding to what kind of eating disorder they may or may not have, as and also or the severity of the eating disorder. Because one of the features for eating disorder is that people experience extreme shame when they're doing disordered pattern eating, so they try their best to cover things up. Secrecy is definitely a priority regarding their eating disordered behaviors. Here's an overview of all the feeding and eating disorders in the DSM-5. As you can tell, there are 6 major disorders listed. They are pica, rumination disorder, avoidant restrictive food intake disorder, anorexia nervosa, bulimia nervosa, and binge eating disorder. Additionally, there's also other specified feeding or eating disorder that I did not include in this list. Now, let's go into details to check out each one of these disorders. Pica was used to be included in the disorders of infancy and childhood in the DSM-4. Pica refers to a situation where individuals just eat items that are not food, right? They don't typically thought of as food, and they also don't contain significant nutritional value. These objects include like hair, dirt, or paint, etc. In order for individuals to receive this diagnosis, the duration for this behavior is to be at least 1 month. There's also a minimum age for this diagnosis, which is 2 years old. The reason for this age is because for especially in infants, mouthing objects or simply like just putting small objects in the infant's mouth by themselves is actually normal, right? It's a normal part of the development. We want to be able to rule out that normal development behavior from pica. That's why. Some of the typical substances that a person usually use in pica include paper, soap, cloth, charcoal, hair, string, clay, ash, ice, pebbles, paint, and there may be some others. I remember when I was a child, I used to eat eraser, and it's like a competition between me and other um, like children friends. I don't remember why I was doing that, but just remember it's a thing that everyone does it. Um, Although the child onset is commonly reported, like about 25% to 30% of the onset is children, there's still a chance that a pica be experienced by pregnant women during their pregnancy. Depending on the substances the individual has been taken in, the situation can be fatal for that individual. In addition, pica is commonly comorbid with autism spectrum disorder, intellectual development disorder, schizophrenia in children, and OCD. So that's just something that to keep in mind. Next one is rumination disorder, which refers to the repeated regurgitation of food occurs for at least 1 month. The regurgitated food may be rechewed, reswallowed, or spit out. When individual is doing all of these, they do not appear to be that they're making an effort or they feel disgusted or upset. In order to receive the diagnosis, the behavior of regurgitation should be frequent. Usually it's a daily behavior or at least for several times per week. Individuals can receive the diagnosis across the lifespan. So this could occur in infancy, childhood, adolescence, or adulthood. And at any age, this condition can cause malnutrition and it can be extremely or potentially fatal in infants. Next, we have avoidant restrictive food intake disorder, or simply ARFID. This disorder has been previously called selective eating disorder. Individuals with this diagnosis are featured in that their eating are not meeting nutritional needs. It sounds like it can be a little bit similar to anorexia nervosa, but the biggest difference is that for people with ARFID, they don't really have the concern of their own weight and their body image. This disorder can present in children, adolescents, and adults. So what are the causes for ARFID? Even though the research is still limited, several causes have been identified, such as the individual they're not interested in eating or food. There maybe some individuals have some sensory issues so that they actually have food aversions because of how they feel like when they're put them in the mouth. There's also a likelihood that they have a trauma, either themselves get choked or they watch someone choking. Individuals with some special stomach or GI conditions may not want to eat food because of the negative consequences. And then there's also this food beliefs that are shaped by the culture. What is healthy eating? How much protein, fat should I be eating every day? Should I be eating carbs at all? Those things can be very influential, especially among adults and adolescents. People with ADHD, intellectual disabilities, as well as autism spectrum conditions are more likely than other people to develop this disorder. Children who did not outgrow their picky eating, or maybe they just always had a severe picky eating, are also have a higher likelihood to have this disorder. Children with anxiety issues are also can be comorbid with this disorder as well. Anorexia nervosa, or simply AN, is a disorder that featured in the restriction of eating because of the concerns over their weight and body image. People with this disorder experience an intense fear of gaining weight, and they also have a distorted body image. This kind of fear cannot be relieved just by the loss of the weight, and the concern about gaining weight could increase as the weight falls. Another feature is a restrictive food intake. Their preoccupation with calories and their compulsive over-exercising. There are two subtypes here. There is F50.01 restricting type, and the other one is F50.02 binge eating / purging type. Even though there are two subtypes, the crossover between the subtypes is not uncommon. We can also specify the severity of AN based on the body mass index number. So what are the warning signs for AN? In other words, how can we know ahead of time if someone has a tendency to have AN? And there are actually a lot of them, but I like to highlight the following things. So the first one is the individual is super preoccupied with weight, food, calories,
fat grams, and dieting. They spend large amount of time studying those things, talking about those things, and usually follow restricted diet. They also withdraw from usual friends and activities, and they become a bit more isolated, and they also become kind of secretive. And they sometimes, even whenever they are out eating, they are kind of concerned about eating in public for some reason. Another feature is the rigidity in life. So there's this tendency that this individual becomes more and more rigid in their lives. So that could get that could be that this person has limited social spontaneity. This person has a strong need for control. There's also inflexible thinking. They also has overly restrained initiative and emotional expressions and things like that. And then the last uh, warning sign I have here is there are actually lots of physical symptoms that you can see or hear from the person. So there's usually complaints of like constipation, abdominal pain, cold intolerance, feeling tired all the time, or maybe they feel that they have excessive energy. There's also stomach cramps, non-specific GI complaints. Those are all associated with usually malnutrition or skipping meals. People would also experience dizziness, fainting, sleep problems. And for females, it's not unusual for them to experience menstrual irregularities. People complain about their the weak muscle, and you can also sometimes see from their hands they look like they have mottled hands and feet, or swelling of the feet, and the overall impairment of the immune functioning, like they get sick a lot. People with anorexia nervosa usually have a low self-esteem or a very unstable self-esteem because it's very highly dependent on their perceptions of their body shape and their weight. If, for example, that they've lost some weight, that's usually perceived as a highly important achievement. So they may feel very happy and their self-esteem get boosted. But if they just gained maybe like zero point 0.5 pound, they may feel extremely depressive and then their self-esteem just drop down. People with AM usually also have some associated symptoms such as depression and OCD symptoms because it's all about control. They want to control things. So that's why on the previous slides there's one of the warning signs that they are experiencing rigidity in their life because they just want to control everything. So they've lost that spontaneity in life. And believe it or not, people die from this diagnosis, from this disorder. People with AN has the highest mortality rate across all mental disorders. Therefore, as therapists, it is of great importance that we evaluate the suicidality um, when working with this population. Bulimia nervosa refers to the situation where individuals eat very large amount of food followed by compensatory behaviors such as vomiting or they may use laxatives. And so other features include the obsessive fear of gaining weight and as well as the distorted body image. So it's very similar to anorexia nervosa. And there's also cycles of binge eating, followed by the use of compensatory behaviors to avoid weight gain. Even though in DSM there are not any subtypes, but in clinical settings, we usually like to put them into two subtypes. They are either purging or non-purging subtype. So how do we know if someone may have bulimia nervosa? There's usually an evidence of binge eating, such as
the disappearance of large amount of food in such a short period of time, or you may see lots of empty wrappers and containers. And they all, all of these can indicate the consumption of very large amount of food. And you may also find out some evidence of purging behaviors, such as infrequent trips to the bathroom after meals, like the individual just disappears after the meals, and there may be smells of vomiting. The individual may use mouthwash, gums in excessive amount to kind of cover the smell. There's maybe a presence of wrappers and packages of lactives. They may even have calluses on the back of their hands and knuckles because they used to do self-induced vomiting. And they also may appear very uncomfortable eating in public because they are very self-conscious about it, and they usually don't feel comfortable eating around many people. Individuals with bulimia nervosa usually are within normal weight, or they may be slightly overweight, but usually they look normal. Um, and people in this condition, unfortunately, they wait on an average of 6 years before pursuing treatment, just because usually, if their weight is normal, and it's kind of hard for people to find out. As mental health professionals, we need to pay attention to the potential co-occurring mental health conditions. Self-injury is very common. To some extent, self-induced vomiting is a way of self-harm, right? And there's also suicidality evaluation is really important, because again, similar to those who with eating disorders, people with BN also feel isolated, they feel lonely, they kind of withdrawn from the social situations. So yeah, life is not very easy for them. And some of them would also um, cope with this loneliness, this depression with substance. So substance abuse is a comparatively common behavior in this population as well. Impulsivity is another one. People may uh, manifest in like risky sexual behaviors or shoplifting and things like that. The primary feature for binge eating disorder is that individuals eat very large amount of food over a very short period of time, and they also experience the loss of control. In addition, there is no compensatory behaviors. And you can read the rest of DSM-5 diagnostic criteria here on the slides. Believe it or not, BED is actually a new disorder in the DSM-4, because in the previous edition of DSM, BED was listed as a subtype of eating disorder no otherwise specified, which is very similar to the other specified feeding and eating disorders. As we know, insurance companies are less likely to reimburse treatment with the diagnosis that without not very specified diagnosis, like other specified or non-specified, which was the category that BED used to be in. And right now, this new diagnosis allowed clients who suffer from BED get paid by the insurance, or the treatment get reimbursed by the insurance companies. BED is also the most common eating disorder in the United States. What do you think of that? Is that surprising to you, or does that make sense? People with BED experience large amount of shame, distress, guilt after they eat so much. They also experience very low self-esteem. BED disrupts normal eating behaviors of individuals, such as eating throughout the day with no planned meal times. Individuals may skip meal or take small portions of food at regular meals, and they just start eating a lot at the end of the day. Individuals may also engage in sporadic fasting or repetitive dieting. And people with BED also have noticeable fluctuations in their weight. So their weight is both just ups and downs. There are some other problematic eating behaviors that are not recognized as a disorder or as disorders in the DSM-5, but they usually they're on the rise and they're sometimes associated with one or two eating disorders. So the first one is orthorexia. This one refers to individuals' obsession with proper or healthful eating. These are the kind of individuals that are always checking the ingredients list, and they may cut off sugar, for example, from their meals, or they may take off carbs or fat in total. They are spending large amount of times and occupation to kind of engage in the very restricted eating patterns that in their mind has been recognized as very healthy or labeled as healthy. The next one is laxative abuse. Basically, it's just the repeated or the frequent use of laxatives in order to remove those unwanted calories. And the last one is compulsive exercise. This refers to the excessive and extreme physical exercises that significantly interfered with the person's areas of their life. Individual can have all three of these. On top of that, they may also have one or two other eating disorders. Okay, now we have the good understanding of different types of eating disorders. Now let's talk about assessment. First of all, you would like to identify the primary eating disorder symptoms. Does this individual engage in binge eating episodes, or they avoid as much food as possible, or they only avoid certain types of food? Were they eating something inedible? Or maybe there's also some compensatory behaviors such as purging or using lactives or excessive exercising. Secondly, you want to explore the motives behind their eating disorders. Why are they doing that? Are they doing it because they're really concerned about their weight? They either want to gain lots of weight or they want to lose lots of weight. Or maybe they've experienced some trauma, which is very common actually among people with eating disorders. The prevalence of trauma among this population is, according to research, as high as 90%. It is likely that they're using eating to cope with the aftermath of the trauma. Or maybe they are, for some reason, experiencing very intense feelings and they just want to kind of shut them off or kind of numb, make themselves feel like numb. And maybe there are other motives. Figuring out what the motivations are can help you so much with, well, first of all, help the individuals to get more insight, and secondly, it helps you with your treatment planning. The next one is refers or not. The next one is about frequency and duration of the eating disorder behaviors. As we know, in DSM-5, we always pay attention to the requirement of the timing for symptoms, like the duration of the symptoms. So it's really important for us to also clarify with that. How often do they engage in those behaviors, and how long have they been doing that? Is that like 1 month, 2 months, 3 months, or maybe they've been doing that all their life? The next one is to explore what a typical good day and a bad day of food looks like. These two questions I personally find to be very helpful for a multitude of reasons. First of all, my idea of a good day or a bad day can be drastically different from your idea of a good day and a bad day of food. By getting a very contingent or rich description of their idea of a good day and a bad day of food, you can understand your clients a little bit better. Also, for many clients, their ideal for a good day can be very unrealistic. For example, I had a girl who was telling me that her good day was to, eat a fruit in the morning, eat a very small sandwich at noon, and eat nothing at all at night, but she will drink some kind of milkshake. So the intake for her food is only like a couple hundreds of calories, and she was in her 20s. That is not very healthy, apparently. She's definitely not getting enough calories, but in her mind, that is a good day of food. Another reason why we ask this question is that we can hopefully explore or see or identify kind of pattern. For example, a client may only eat excessively when she's watching a TV or when he is watching Netflix or when they're doing activities with their friends, right? So if you figure out that pattern, that gives both you and your clients a perfect opportunity to talk about, okay, what can we do here? Any kind of interventions we can throw out there so that we can help you, um, you know, um, develop better coping strategies during those times. So yeah, I highly recommend you to ask those questions to your clients. Next one, you may want to know if the clients are using any kind of tools to track their progress or to motivate themselves. By tools, I really meant any kind of maybe like calorie counters, such as weighing self, or also the weight trackers. So weighing self, MyFitnessPal, ThingsPal, Anna Mia hashtags, and many more. And then the last one, but not the least one, is to kind of explore the client's relationship with their body image. As we know, for some individuals with some eating disorders, they are highly concerned about their body image, or they just have a very negative body image. And for some others, they don't really care if they have like other kind of eating disorders. So yeah, it's kind of important for you to also figure out about your client. It can help you with the diagnosis and also with the treatment planning. There's also standardized testing you can use. I recommend the questionnaire on eating and weight patterns 5, and there's also eating disorder examination questionnaire. So something about assessment is that your client will, or like they are not necessarily to be 100% honest to you because they feel ashamed of their behaviors, right? And it also depends on your relationship with your client. So, no, they don't necessarily not, especially in the first session, they may not be honest to you, and that is okay. You just, continue developing the relationship with them, continue doing assessment periodically, and eventually you will get there. When it comes to treatment for individuals with eating disorders, multidisciplinary approach is definitely the way to go. If you still remember from the beginning, the eating disorders are very highly treatable. It's just that the clients would need some structured, sometimes intense, and integrative care. And that's what multidisciplinary approach is all about. So basically, the client will have a team of professionals to help them with the treatment.
Psychotherapy or counseling will be provided by mental health professionals. Um, Nutritional therapy can be provided by nutritionists or registered dietitian because these professionals can help the clients to address their complex nutritional needs through making some meal plans and also manage their symptoms. Medical physicians can be especially helpful with those who reported with a decline in their immune system. Psychiatrists are also important in this team because not only for eating disorders, but also for any kind of comorbid mental illness, which is very common. And then there's also speech and occupational therapists. They're especially helpful with those who have avoidance restrictive food intake disorder. As far as counseling modalities, cognitive behavioral therapy again has been used, and then dialectical behavioral therapy as well as motivational interviewing are also good approaches to use. The counseling doesn't have to be in an individual setting, could also be group therapy or family therapy. When necessary, hospitalization is a good way to protect the client's safety because a lot of times clients may have resistance. So especially those who with like they don't have much calories taking every day and their health is deteriorating. So sometimes we have to kind of put them in a hospital so that they can get the proper treatment there. There are also some programs that can be delivered online. As far as medications, Prozac is usually used for bulimia nervosa and Vyvanse for binge eating disorder. At the bottom of the slide, I have a link for a YouTube video, which is a video picturing the Dr. Judith Beck using cognitive behavioral therapy with a client who's struggling with weight loss. So if you're interested, it's a very short video for you to watch. As counselors working with this special population, we should be able to do the following things. First of all, we should be willing to explore client food patterns as well as their relationships to the body size and the body image without any judgments. So the key here is to have that accepting attitude so that we can validate the client's experience and at the same time documenting those food patterns and the relationships without any biases. Secondly, at a certain point, we may need to do referrals. So make sure that you check with those referrals to know they are actually a good place for the client to go. The next one is regarding to nutritional advice. I know many of us, myself included, are probably feel like we are also we have some level of knowledge about nutrition. Actually, everyone does. Everyone does have some kind of perception or theories about what well-balanced meal look like. But we should really refrain from giving those advice to our clients unless we are formally trained, unless you have a certificate in like a dietitian. I know it's hard, but we need to do that. And then the last one is always remember to consult with your supervisors, with other professionals, and sometimes even with professionals from other professions. And remember, you are also a human being. So in your leisure time, I would encourage you to kind of explore your perception of your body image. How do you like your body image? And also try to gain the awareness of body privilege. Do you think you have certain privilege because of your body size? The next one is to explore your relationship with the attitudes, relationship with food, as well as the attitudes um, towards food. How do you like food? How do you perceive food? What's your theory behind eating? Also explore the food and eating in your cultural context. I know I'm from China, so my love language is definitely feeding people, and that's not unique to myself. I know at least in my family that's a big thing, right? So food to me means loving, caring, and the togetherness, and even some kind of harmony or almost like a spiritual in certain way. So what does that mean to you? What does food mean to you in your cultural context, in your family, um, growing up, right? And you also want to identify any kind of personal biases that you may have towards certain eating behaviors or maybe like eating cultures, things like that, so that you can become non-judgmental and more accepting of your clients' experiences. If you have any thoughts, please click on the link down below. On page 3, you should be able to find a Jamboard, and that's where you can share your thoughts on the entire lecture or also on your own reflection. Everything is anonymous. You're welcome to do that. And that's it. You have reached the end of this lecture. Thank you so much for going through this lecture with me. I hope this information can be a bit helpful with your study. If you have any questions, any thoughts or comments, please make sure that you either put them on the Jamboard or feel free to email me, or maybe you can just jump in to my office hours. I would be love to talk to you about those thoughts and comments. Other than that, I look forward to see you on Monday. Bye.